So today we are going to be talking about pre-eclampsia, which is falling under the hypertensive disorders in pregnancy, part 2. So if you haven't watched part 1, you have to watch part 1 before watching this one. And if you haven't subscribed, subscribe now and like this video. Okay, let's start. So let's start with the definition. So we already did the definition in the first part, but since this is a new video, I'm also going to define pre-eclampsia. So it is a multi-organ disease process of unknown etiology characterized by the development of hypertension and proteinuria after 20 weeks of gestation. Or you can also define it as the elevated blood pressure after 20 weeks of gestation, so which means more than 140 millimeters of mercury systolic or more than 90 millimeters of mercury diastolic. And also there should be proteinuria over more than 0.3 24 hours with end organ damage. And it also has to, everything in preeclampsia, the hypertension has to completely resolve by the 6th week postpartum. So we'll be talking about the risk factors for preeclampsia. So number 1, we have prion gravida, and the evidence in support of this theory is that the risk of preeclampsia is highest in a first pregnancy and decreases with the length of time a woman has lived with the father before becoming pregnant. And also furthermore, there is also risk. The risk is also increased in multiparous women who are pregnant by a new partner. Chills. So just be advised that this is for education purposes only, not to end people's marriages or to be used for raising suspicion of any matter. This is just for education purposes. Yes, but that's the facts. That's what they say, and it's true. So the second risk factor is multiple gestation. We have molar pregnancy, previous history of preeclampsia, obesity, then we have family history. We also have extreme of age, less than 20 or more than 40. You also have genetic predisposition, which can be maternal, paternal, or maybe they may have thrombophilias and the like. Then we also have 10 years or more since last baby. Then we have pre-existing medical conditions such as chronic hypertension, chronic renal disease, pre-gestational diabetes mellitus, antiphospholipid antibody syndrome, and also there are other routines or things which you can do to actually prevent preeclampsia. So prevention can be through routine supplementation with calcium, magnesium, and omega-3 fatty acids or antioxidant vitamins. It has been shown to be effective. And calcium supplement reduces the risk of developing preeclampsia in high-risk women and those with low dietary calcium intakes. So they can actually be given calcium supplements to prevent the development of preeclampsia in those patients. We are now going to talk about the pathogenesis of preeclampsia. So there are various theories of pathogenesis of preeclampsia, and one of them says that during formation of the placenta, the trophoblast cells of the embryo invade through the deciduum, which is the endometrium during pregnancy, and also part of the myometrium. And this is done so in order to assess the spiral arteries, which are terminal branches of the uterine artery. Now for this to happen successfully, the trophoblasts have to invade the deciduum effectively, while the spiral arteries also have to undergo remodeling from narrow blood vessels to large tortuous blood vessels that allow large amounts of blood to pass and reach the uterus. In the first trimester, which happens about 10 to 12 weeks, there is endovascular trophoblast invade up to the decidual segment. This is what I refer to as the first trophoblast invasion. Then in the second trimester, which happens about 16 to 18 weeks, another wave, which is the second wave of trophoblast, invade up to the myometrial segment, which I call the second trophoblast invasion. So first trophoblast invasion is they just invade up to the decidual, which is the endometrium. So that's the first invasion up to the endometrium. Then the second invasion, they invade up to the myometrial segment. So for this process, it is necessary because it replaces endothelial lining and the masticular arteriole bifibrinoid formation, and the spiral arteries are actually uh, shaped or transformed, and they become distended, tortuous, and funnel shaped. They actually become big. So in order for this physiological change, it actually transforms the spiral arteries into low resistance, low pressure, high flow system, and they allow more blood and high flow system to the uterus. So what happens in preeclampsia is that there is failure of the second wave of endovascular trophoblast migration, and there is reduction of blood supply to the phytoplacental unit. So which means that there is in the spiral arteries they still remain with high resistance, high pressure, low flow system. So that's the reduced supply to the phytoplacental unit. And what happens to organs is that in the kidneys there is endothelial damage, which leads to proteinuria, and in the lungs the endothelial damage will lead to edema, and in the liver there is going to be microvasculature injury or microvasculature injury, which is going to lead to hepatic necrosis, and also in the blood vessels there is going to be hemolysis, which will occur due to sharing of the erythrocytes as they traverse through the capillaries and laden with platelet fibrinoid. Then also in the brain there is going to be cerebral edema and vascular spasms or cerebral ischemia, which is going to lead to convulsions. So let's go through how to make a diagnosis of preeclampsia. So in clinical practice, we usually use the criteria of 2 elevated blood pressure, and they have to be measured 6 hours apart, and a proteinuria of 300 milligrams in a 24-hour urine correction. Then also a 24-hour determination is the most accurate because urine dipstick can be affected by variable excretion, maternal dehydration, and bacteria. Then also a random urine protein or creatinine ratio is actually of less than 0.21, indicates that significant proteinuria is unlikely, with a negative predictive value of 83%. However, confirmatory 24-hour urine protein determination is recommended. So this is just saying that when making a diagnosis, make sure you measure blood pressure 2 times and 2 times 6 hours apart, and your proteinuria has to be either 1 to 2, or it starts from 1 to 2, since there is, according to the next part we're going to do, is saying there is 1 to 2 which is mild and 3 to 4 which is severe. But the lowest is they should have a proteinuria of more than or of 300 milligrams in a 24-hour urine correction. So sometime back, preeclampsia used to be diagnosed by the 3 to 15 rule, which just means that the systolic pressure more than 30 millimeters of mercury above baseline, and the diastolic pressure of more than 15 millimeters of mercury above baseline as well. So that was one of the diagnostic criteria, but it's no longer used because it is non-specific, and also there's also another criteria which was used, which was generalized edema, so affecting the face and hands. So it was impressive, and was only considered a diagnostic criteria, but it is now disregarded as one because it is too variable. It is variable, so they have stopped considering edema as one of the diagnostic criteria in preeclampsia. So we just use the ones we talked about in the previous slides. So let's now talk about classification of preeclampsia. So preeclampsia can be classified, or it ranges from mild to severe, but there is no moderate, so it's just mild preeclampsia and severe preeclampsia. So let's start with mild preeclampsia. So this is blood pressure equal or more than 140 or over 90 millimeters of mercury, but should be less than 160 over 110, and should be taken at least 6 hours apart with the patient on bed rest. Then also proteinuria should be of 1 to 2 plus on dipstick, or equal to or more than 300 milligrams per 24-hour urine correction. So that's mild preeclampsia. That's how we make a diagnosis of mild preeclampsia. Then severe preeclampsia, this is when the blood pressure is equal to or more than 160 over 110 millimeters of mercury, and should be taken as well for at least 6 hours apart with the patient on bed rest. Then the other criterion is there should be proteinuria of more than 5 grams per 24 hours, or 3 to 4 plus, or 3 plus alone on 2 random samples 4 hours apart. Then also the last criteria is that there should be manifestations of end organ damage, which we are going to, or end organ disease, which we are going to talk about in the next slide. So we talked of manifestations of end organ disease for severe preeclampsia. So these are the manifestations, and also there's a mnemonic, though it's hard to remember. Is Shrevo TH, but I just read it as Shrevo teeth or Shrevoth. So the C stands for cyanosis, H stands for headache, which is due to cerebral edema. Then there's respiratory distress and pulmonary edema. Then there's also epigastric pain or upper quadrant pain. This is usually due to the epigastric pain results from hepatocellular necrosis, the edema, and the ischemia, which stretches the Gleason's capsule. That's why the epigastric or right upper quadrant pain comes from. Then there is also visual disturbance, which results from decreased cerebral perfusion of the occipital cortex. Then there is oliguria, oliguria is just less than 500 mils in 24 hours of it. So urine less than 500 mils. Then there is thrombocytopenia, which is of course low platelets. Then there is so the low platelets is as a result of vasospasms induced microangiopathic hemolysis. So there's hemolysis which causes the thrombocytopenia. Then lastly, we have the HELP syndrome, which so HELP, the H is for hemolysis, the second the E and L stands for elevated liver enzymes. Then lastly, we have low platelets. So this sometime back it used to be classified as a separate syndrome, but current thinking categorizes it as a manifestation of preeclampsia. So that's why it's here on the manifestations of severe preeclampsia, and it is associated with a significant maternal and perinatal morbidity as well. So, before we talk about the investigations, it's better to know the complications so that even as you are making a diagnosis, you know exactly what goes wrong. So, on complications, we have fetal complications and maternal complications. So, fetal complication, we have intrauterine growth restriction, oligohydramnios, intrauterine demise, placental abruption, placental insufficiency, and of course, there are also others. Then there is maternal complications where we have eclampsia, pulmonary edema, HELP syndrome, acute renal failure, intracranial hemorrhage, disseminated intravascular coagulopathy. These are some of the complications of preeclampsia. Investigations of preeclampsia so include bedside clotting time, your urinalysis, your full blood count, urea and electrolytes, as well as creatinine. Then we have liver enzymes and liver function test, your coagulation profile. Then you do ultrasound and Doppler ultrasound as well. So these are your investigations you do for preeclampsia. We are done with the investigations and the complications and the like. So let's manage according to the classification. So management of mild preeclampsia is actually similar with gestational hypertension, if not the same actually. So the principles is that one, you have to treat the blood pressure with antihypertensive. So use your nifedipine and methyldopa, which are recommended in pregnancy. Then of course you have to review your patients, and you have to deliver at 38 weeks gestation. So you just have to see the patient every after 2 weeks until the time of delivery. Then you have to change when they reach 28 weeks. You are seeing them before 28 weeks. You are seeing them for 2 weeks. Then after they have gone above 28 weeks, you start seeing them weekly until delivery. Then the last part is you have to treat with postpartum antihypertensive. So your postpartum hypertensives are your nifedipine and your atenolol. So you have to give them after delivery. You have to start giving them this. Management of severe preeclampsia. So we have principles which include number one principle is that you have to control your blood pressure. So use your antihypertensives such as the nifedipine and methyldopa. And if the diastolic blood pressure has gone above more than 110, you have to administer adrenaline, which is fast acting and can drop the diastolic blood pressure faster. 5 milligrams IV slowly over 15 minutes, and you have to repeat every 30 minutes as they need rise. So the case this is just an addition to the oral antihypertensives. The second principle says that you have to prevent convulsions. So you have to use your magnesium sulfate loading dose and maintenance to prevent seizures. Then after I've given this, you also have to continue the magnesium sulfate for 24 hours after delivery. So for the calculations and how to give magnesium sulfate, we're going to talk about in part 3 for eclampsia. So if you haven't subscribed, make sure you subscribe so that the time the video will be out, you'll be notified, and you make sure you like this video as well and share. So the third principle, it says that you have to deliver within 12 hours, within 24 hours. So deliver within 24 hours. So method of delivery can be vaginal delivery or cesarean section. So vaginal delivery may be commenced in vertex presentation, which is just when the egg presents first. So it can be commenced by either you have to induce labor by amniotomy plus oxytocin, where you combine two methods. If the cervix is favorable, or you use your prostaglandin vaginal tablet if the cervix is not favorable, or you have to do your cesarean section when as indicated as the obstetric indication, maybe such as in fetal distress, rate deceleration when it occurs with oxytocin challenge test, or failure of induction of labor, Other indications as well, maybe contracted pelvis, malpresentations. That's why investigations were necessary. We are also trying to gauge what would be my method of delivery for this child. So some experts, they are actually recommending cesarean delivery for fetuses younger than 8 weeks when the cervix is not ripe. But a trial of indication, trial of induction of labor may be considered, and that's why you have to gauge and you have to assess the patient yourself. That's the end of the video on preeclampsia. So thank you for watching. You also make sure you go to part 3 on eclampsia, and also it's also going to cover magnesium sulfate, your loading dose, your maintenance dose, and just as well as your calculations for each, because they are important, including the antidose for the sign, including the antidose and the signs of toxicity and the like. So make sure you like this video, you subscribe, and watch part 3 on eclampsia.